set the stage about how you think about differences between the adult eustachian tube versus the pediatric eustachian tube, thinking about, anatomy and kind of some of the different pathology you see when you kind of compare and contrast those groups.
Well, thank you. First, I should just let folks know that I am a consultant for the Clarent Corporation. And as a consultant, I'm just paid for my time and expenses. So I have no equity interest in the products and no royalties from any of the products. So I'm going to speak to you about my academic experience with this. So so the adult eustachian tube, the current indication for the balloons, and we know the cartilaginous portion, which is the target of our surgery, it's the cartilaginous portion that serves as a functional valve, and that's where the pathology is, and that's true in the children as well. So the surgery is going to be targeted to the cartilaginous portion. In an adult, it's about 25 millimeters in length. So that's an important thing to keep in mind, because when you're working with your balloon catheter, you want to be aware of the length of the balloon. We don't want these to get up into the bony part of the eustachian tube. First of all, most of the pathology is not there, and that's also where the internal carotid lies. So we don't want to get our balloons up into that portion. So we're thinking about 25 millimeters. We looked at CT scans of over the age ranges, pediatric age ranges, from under 2 years old all the way up to 18. And it does lengthen. We've been previously taught from Bluestone's work that the eustachian tube is mostly full length by age 8. It actually can continue to grow a little bit farther, but the steepest curve is in that underage group. So the indication for pediatric balloon dilation is going to be 8 and above, because most of them are going to be close to full adult length. And from the measurements that we took, it was about 25 millimeters. Now, by the time you got to age 15 and above, it was up to maybe 27 millimeters on average. So remember, that's a range, but this is a rough guide. So think about that, 25 millimeters. The other important difference between the kids, just anatomically, is the height from the floor of the eustachian tube up to the orifice of the eustachian tube also gets larger as we age in our development. So younger kids, we've been taught that the eustachian tube orifice is going to be taken up at a flatter angle, and it's very true. So you'll have to be looking a little bit lower in the younger kids. The orifice may be a little lower than you think. So there's a height difference, and that's going to change the angle that you go from the floor of the nose. These balloon catheters travel along the floor, and then you angle up toward the eustachian tube orifice. So it's going to be a flatter angle in some of these kids. And that's a little variable at that 8 to 12-year age. The other big difference is there's a lot more inflammation in the kids. So they've got the adenoid hypertrophy. There's adenoid tissue that sometimes is spilling over onto the torus tubarius. The torus, the tubal tonsil tissue can be very robust, lots of cobblestones. And it can sometimes be hard to find the orifice. So sometimes you have to probe around there to actually figure out where's the anterior pillar, where's the torus tubarius, and then somewhere in between there and install this hypertrophied tissue is a lumen. And it can be very friable in the kids too. So the anatomy is a little trickier in the children, so just extra caution.